Extracorporeal photopheresis for Colitis induced by checkpoint inhibitor therapy. Definition: Extracorporeal photopheresis has been an effect streaming photograph versus heart disease.
A little bit about our apheresis service at UCI. I think this is really excellent. So our service handles sort of a lot of the blood-related support for the hospital. So we are the UCI transfusion medicine service, which is under the direction of Dr. Irina Maramika. She's the medical director, and then I'm the associate director. We have on the apheresis side, Susan Angel. She's our blood donor center and apheresis program manager. The scope of our service, we oversee we have 2 fixed site blood donor centers. So we have one on the medical center campus, and we have one down on the UCI campus in Irvine. We also have a mobile, so a bus that goes around Orange County. You may have seen it. And we also oversee all of the therapeutic apheresis, both inpatient and outpatient at UC Irvine Medical Center. So our operation actually is able to provide about 60 to 70% self-sufficiency for the blood products that we use at UCI. I'm very proud about that. So this is just over time from 2013 until the end of last year. This purple line on top shows sort of the growth of our outpatient apheresis program, and this is the inpatient program. And in a way, you could think of this as being sort of, we're able to support patients that ordinarily in the past would have been in the hospital for pheresis, now in our little apheresis clinic, and I'll show you some pictures of that later. So apheresis, what is this word, man? This is a crazy word. Okay, so it comes from the Greek. So apo is from, and then hereo, take. So they put it together and it's epherein.
Application in nursing. Approximately 15% of the patients develop serious immune-related adverse events.
It's an exciting area of cancer research that is changing the way we think about cancer treatment. Immunotherapy works by using the body's immune system to fight cancer. The immune system is a complex network of organs, tissues, and cells, and the substances they make. Immunotherapy uses different ways to boost the immune system to do a better job of killing cancer cells. This video describes one type of immunotherapy that uses immune checkpoint inhibitors to treat cancer. T cells are a type of immune cell and are powerful weapons the immune system uses to fight cancer. Immune checkpoints on cell surfaces help control an immune response. Usually immune checkpoints keep T cells inactive, that is, in an off state, until they're needed. This keeps the T cells from harming normal cells. Cancer cells can take advantage of these checkpoints to switch T cells off. This keeps the cancer cells from being killed. Immune checkpoint inhibitors are drugs that block the checkpoints. This frees the T cells to attack the cancer. Immune checkpoint inhibitors are an effective way to treat some types of cancer, but they don't work for every patient and can cause serious side effects. To learn more about immunotherapy, visit cancer.gov/immunotherapy or call 1-800-4-CANCER.
Pros and cons. Autoimmune colitis occurs in 20% of the cases and can become corticosteroid refractory.
Cancer immunotherapy is an innovative therapeutic approach to treat cancer by mobilizing a patient's own immune system instead of targeting tumors. It can conceivably be effective against any type of cancer. Immune checkpoint inhibitors, a promising new class of cancer drugs, can unleash the cancer cell killing power of the immune system by blocking the hardwired inhibitory pathways that keep T cells in check. The effect can be enduring and long-term, allowing the body to respond rapidly should a tumor recur.
Immunotherapy offers the potential to complement the high-impact short-term benefit of molecularly targeted therapy with a potentially more durable response mechanism.
Our immune system provides surveillance activity to kill tumor cells in the body. When a T cell encounters a tumor-specific protein carried by an antigen-presenting cell, the tumor antigen can trigger antigen-specific T cell activation and expansion. These activated tumor antigen-specific T cells will eliminate the tumor cells. Checkpoint molecules help keep activated T cells under control. They can be stimulatory or inhibitory. Inhibitory checkpoint molecules provide a negative feedback mechanism, like a brake on a car, to attenuate the function of activated T cells and prevent an overreaction that could damage tissues and organs. Cancer cells can utilize the body's immune inhibitory checkpoint system to blunt T cell action and enable the tumor to develop. Programmed cell death protein 1, or PD-1, is an example of an inhibitory immune checkpoint receptor. When PD-1 interacts with a ligand such as PD-L1 and PD-L2, which may be expressed on normal or tumor cells, activated T cells will be turned off, inhibiting T cell signaling. Some tumor cells express high levels of inhibitory immune checkpoint ligands, such as PD-L1, allowing them to avoid destruction by T cells. Inhibitory immune checkpoints can be blocked using monoclonal antibody-based drugs. Immune checkpoint blockade prevents the binding of specific ligands on tumor cells to their inhibitory immune checkpoint receptors on T cells. These powerful antibody drugs can significantly boost a patient's immune response to a tumor. They may also cause serious side effects, such as an autoimmune response in some people.
The FDA approved the first immune checkpoint inhibitor in 2011 to treat advanced metastatic melanoma.
Issue applied to Ecuador. Autoimmune colitis occurs in 20% of the case and can become corticosteroid refractory. We hear reports of patients suffering from ipilimumab nivolumab-induced colitis.
Thanks, John, for inviting me. It's a pleasure to be here. First, I'd like to invite you to our upcoming lymphoma meeting, which will be next month. And the information is down there on the website. If you're interested in registering, please do so. All right, so immune therapy is picking up pace lately, and there's different versions of it so CAR T cells, I think it's getting a lot of tractions lately. Bispecific antibodies, the experiment was done with blinatumomab, although it's a relatively difficult drug, but it was proof of principle that this bispecific strategy is a good idea to pursue, and there's different versions of this. The DARTs and the true bispecific antibodies also gaining tractions lately, and immune checkpoint inhibitors. And I'll focus mainly on immune checkpoint inhibitors in the interest of time. And for simplification, you can think of T cells are controlled, activation is controlled by sets of proteins on the surface that can activate it or inhibit its activation. So these are like accelerators, and these are like the brakes. So if you want to activate T cells therapeutically, you need to use agonistic or activating antibodies to trigger these receptors, or use blocking antibodies to inhibit these receptors. And there's now a trend to use a different combination of these different strategies. You can use blocking and activating antibodies, or two blocking antibodies. So these are already ongoing in clinical trials.
Conclusion. Combine immune checkpoint inhibitor therapy with anti-CTLA-4 and 18PD-1 antibody is an effective first-line treatment for malignant melanoma.
Okay, the first one is that in general the colitis is more common with the anti-CTLA-4 type of treatment. However, the pneumonitis is more common with anti-PD-1. Now, as a general rule, the anti-CTLA-4 agent like ipilimumab will have more immune-related adverse events. Also, it was shown that at 3 milligrams per kilogram, you have one type of toxicity, but if you give in a second study on a registration trial, when you give ipilimumab at a dose of 10 milligrams per kilogram, the side effects go dramatically up. Currently, it was licensed to use ipilimumab in combination with nivolumab for the treatment of melanoma, and you double the immune-related adverse events on those patients. So, and also the ones with severe immune-related adverse events, you also double it. So you have to weigh the benefits and risks when you're treating these patients on getting the toxicities as opposed to getting the responses also. And when you use combination treatments, at the moment, I don't know, the prices will have to come down if this type of treatment is to be used on the general population. We in South Africa, we're very lucky in Johannesburg that we have access to various clinical trials or expanded access programs to get experience with these agents. But the prices has to go down, and if you're going to use combinations, it's even more money. So the number of patients at the moment that can afford this is very, very, very few.